Good afternoon, everyone, and welcome to today's PHO Rounds presentation on Candida auris, a new disease of public health significance, management of this highly transmissible fungal pathogen. My name is Casey Gambetta. I'm Team Lead, Infection Prevention and Control at Public Health Ontario, and I have the pleasure of moderating today's session. So before we begin the presentation, there are a few housekeeping items to mention. I would first like to start by disclosing that I have no conflicts of interest. To ensure an optimal experience for all, the Zoom chat and audio-video features have been disabled for the session. The Q&A function at the bottom of your window will be available throughout for you to submit any content-related questions. Your questions will then be addressed during the discussion period at the end of the presentation. For any technical issues or to request CME credits, please email capacitybuilding@oahpp.ca. For IPU certificates, please email ipac@oahpp.ca. Lastly, just a quick reminder to everyone that the Ontario Public Health Convention, also known as TOPIC for short, is open for registration. There will be an in-person component on March 26th and a virtual event on April 2nd. And you can check out www.tophc.ca for details. It is now my pleasure to introduce the speakers for today's session, Pega Ashley, Catherine Kerr, and Dr. Lawrence Small. So Pega Ashley is an infection prevention and control specialist at Public Health Ontario with over a decade of experience in IPAC. She holds a Master of Public Health degree, is certified in infection prevention and control, and is a certified public health inspector. Prior to joining PHO, Pega worked as an IPAC professional in both healthcare and public health settings. Catherine Kerr is an IPAC specialist who has been working with Public Health Ontario since 2022 and has more than a decade of experience in IPAC. Catherine earned a Master of Science degree in microbiology and immunology from Western University and has been certified in IPAC since 2012. Prior to joining PHO, Catherine worked as an IPAC professional in both community and large academic hospitals and is a co-subject matter lead for antimicrobial resistant organisms at PHO. And Dr. Lawrence Small is an IPAC physician at Public Health Ontario. He is an infectious diseases physician, medical director of infection prevention and control, and antimicrobial stewardship site lead at Trillium Health Partners in Toronto and Mississauga, Ontario. His clinical activities include a broad range of clinical infectious diseases, and he is involved in ongoing quality improvement and infection prevention and control practices. I am now going to turn things over to Pega for today's presentation.
Thank you, Casey. Welcome, everybody. I want to thank you all for joining us today, and I'm happy to kickstart today's PHO rounds focused on Candida auris. All of the speakers for today have confirmed they have no conflicts to declare. So we're happy that you're sharing this hour with us today, and we hope that by the end of this session, you will have a better understanding of the reporting requirements for Candida auris as part of the disease of public health significance categorization. You will have gain a high-level understanding of Public Health Ontario's CEORIS-related resources and their application, and have improved knowledge of CEORIS, including how to manage cases and outbreaks in your healthcare setting. So I'm going to start by highlighting the key reason for today's session, the new reporting requirements for Candida auris. As of January 1st, 2025, Candida auris was designated a disease of public health significance due to amendments made to Ontario Regulation 135/18, diseases designation of diseases, and Ontario 569 reports under the Health Protection and Promotion Act. This means that it must be reported to medical officers of health. The HPPA designates certain diseases of high concern as reportable to ensure prompt public health responses. Supportive resources for public health units include a memo from the Ministry of Health, as well as a disease-specific appendix under the Ontario Public Health Standards called Appendix 1, which outlines requirements around case and contact management and provincial surveillance requirements, example, case definitions. PHO, in turn, supports Candida auris case and contact management and provincial surveillance requirements by developing additional resources to facilitate data entry into provincial DOPHS database, which is the Integrated Public Health Information System, or IFIS. These additional resources to support public health investigation include the IFIS user guide, which provides a step-by-step process for entering data into IFIS, as well as IFIS Ontario investigation tool used for case management and data collection. I would like to provide a bit of background on what Candida auris is, why we should be concerned, and the importance of stopping its spread. So Candida auris is an emerging fungal pathogen and first Candida species to be classified as multi-drug resistant. Since its discovery in Japan in 2009, it has spread globally, posing an increasing health challenge due to its resistance to several antifungal drugs commonly used to treat Candida infections. While it can colonize the skin without causing infection, nearly 10% of C. auris colonized patients develop invasive infections. C. auris infections can range from superficial skin infections to severe life-threatening invasive disease, particularly in critically ill individuals. Mortality rates for invasive C. auris infection are estimated to exceed 40%. Due to the high mortality rate, its ability to cause persistent outbreaks in healthcare settings, and its resistance to most antifungal treatments, C. auris has become a significant challenge for clinicians and healthcare systems worldwide. The WHO recognizes C. auris as a critical fungal pathogen on its fungal priority pathogens list, and the CDC considers it a public health threat requiring urgent and aggressive action. The Public Health Agency of Canada has been observing the spread of C. auris in hospitals and long-term care settings worldwide, including Canada. This graph depicts the number of reported C. auris cases in Canada from 2012 to 2024. As you can see, the cases are color-coded to represent the different regions of Canada where they occurred. From 2012 to 2024, a total of 62 individuals in Canada have been identified as testing positive for C. auris. Of these, 27 cases were in Western Canada, shown in yellow, 2 in Central West, shown in orange, 31 in Central East, shown in blue, with 22 of these cases being in Ontario, and 2 cases in the Atlantic region, shown in gray. Travel information was available for 25 of the 62 cases, and among these cases, most of them have been travel related. So just to discuss a bit about the disease characteristics, as mentioned, C. auris is a multi-drug resistant fungus that can cause serious infections, particularly in immunocompromised patients and residents. The primary reservoir for C. auris is humans, particularly affecting individuals in healthcare settings. It has also been isolated from environment sources such as healthcare setting surfaces and medical equipment. Transmission occurs primarily through direct contact with contaminated surfaces and environments, as well as person-to-person contact in healthcare settings, including between patients, residents, and healthcare workers. It is notably resilient, persisting on surfaces and in the environment for long periods, which complicates cleaning efforts and increases the risk of transmission. C. auris can colonize the skin, and because patients or residents may be colonized without symptoms, they can easily spread the organism to others. Both infected and colonized patients and residents can shed C. auris on objects and surfaces. For communicability, communicability of Candida auris lasts as long as the individual remains colonized or infected. Only clinical infections should be treated. There are currently no effective strategies for decolonization, and the duration of colonization can vary significantly with no maximum shedding period. Even after an active infection resolves, patients can remain colonized for an extended period, continuing to shed the organism. And lastly, host susceptibility and resistance. Invasive C. auris infection is a serious nosocomial infection that especially affects critically ill and immunocompromised individuals, as I've mentioned. So susceptibility increases in individuals who have frequent or prolonged stays in healthcare settings, those with compromised immune systems, those requiring complex medical care, patients with invasive devices, and those receiving broad-spectrum antibiotics or antifungals. Additionally, it exhibits resistance to multiple antifungal agents, so that's complicating treatment options. Now that we've covered what Candida auris is and why it's a concern, I wanted to briefly discuss the resources PHO offers to support in identifying, managing, and reporting C. auris cases. I'd like to also highlight that PHO has a dedicated Candida auris landing page with all the relevant resources. So what best practice resources does PHO provide? First, we have the PIDAC. We have two foundational resources that outline the IPAC best practice recommendations. First is the PIDAC interim guide for infection prevention and control of Candida auris. This guide provides recommendations for healthcare settings and microbiology laboratories on how to identify and care for patients with Candida auris colonization or infection. Although it's from 2019, the recommendations are still relevant today. And this document is primarily aimed at those involved in IPAC across healthcare settings. Additionally, microbiologists, administrators, and clinicians will also find this information valuable. The second resource we wanted to highlight is PHO's Focus on Candida auris, which provides a comprehensive summary of the epidemiology, mode of transmission, diagnostics, surveillance, and control measures to help reduce or prevent the spread of Candida auris. We've also developed new tools, including the IPAC case management algorithm and a checklist with screening recommendations for AROs, which includes Candida auris. And I'd like to briefly go into more detail on these in the upcoming slides. So as I mentioned, we've created an algorithm to guide IPAC professionals on the steps to take when a Candida auris case is identified. This algorithm includes IPAC recommendations for case and contact management, as well as lab testing. With that said, individual cases should still be managed according to your organization's protocols. All healthcare settings should have policy and procedures to your for the recognition, investigation, and care of patients, residents colonized or infected with C. auris. We recommend you refer to PIDAC's Annex A, screening, testing, and surveillance for AROs, and the routine practices and additional precautions best practice documents for more guidance. I understand that it must be difficult to read on the screen, but this is designed to be an easy to follow one-page document. It starts in the top left with the yellow circle indicating the identification of a new case. From there, it guides you through lab follow-up, initiating additional precautions, ensuring private room accommodations, conducting a point prevalence study, and follow up with contacts, including those discharged or transferred. One thing to note, the reporting requirement step is not included as this algorithm was developed before the C. auris was categorized as a disease of public health significance. Lastly, we have the checklist, which is an antibiotic-resistant organism risk factor-based screening guidance that could be used for all healthcare settings. This tool helps identify patients or residents who may be at increased risk for having an ARO. This tool covers MRSA, VRE, ESBL, CPE, and also includes guidance on screening for Candida auris, as shown in the image. This document may be used as a point of care resource. Following this guidance will help with identifying infected or colonized individuals early, enabling you to implement the necessary IPAC measures. I'll now hand it over to my colleague, Catherine Kerr, to take you through the next slides. Thank you.
Thank you, Pega. Now that we know what Candida auris is and what supports Public Health Ontario has available to you to help with the reporting, we'll move on to talk about the best practice recommendations and the reporting requirements. So screening has been recommended for Ontario healthcare settings since 2019 when the interim guidance was released. As of 2022, only about 35% of responding hospitals in Ontario reported that they were performing any screening or testing for Candida auris. The risk factors for screening patients or residents for Candida auris include whether they have spent time in a healthcare facility outside of Canada within the previous 12 months, if they have been transferred from a Canadian healthcare facility that is experiencing an ongoing outbreak or transmission of Candida auris, or of course, if they have a prior history of C. auris or an exposure to C. auris. And so if the answers to any of those questions are yes, then the patients or residents should be screened as soon as possible for Candida auris carriage. The sites to swab for C. auris carriage include a combined bilateral axilla and groin swab, as well as the nares, and any other previously positive sites or clinically relevant sites. Due to low sensitivity, it is recommended to repeat testing if one negative result is received for a patient or resident with high risk for acquisition of Candida auris. And so you could repeat the swabs at day 7 and 14, for example. So the laboratory methods for processing screening specimens for detection of C. auris vary by lab, and so you should be familiar with the method that your lab uses, as well as the collection kits that they will require you to use. There are two main methods for the detection of Candida auris in screening samples. So we have culture-based methods where specimens are plated onto chromogenic media, and then after incubation, the suspicious colonies, and so there'll be colonies of a specific color, are identified using an automated system such as a MALDI-TOF MS or a commercial biochemical-based test system. Colonies should be sent to Public Health Ontario lab for confirmation and possible antifungal susceptibility testing. The second main method is the direct molecular detection of Candida auris DNA using a PCR-based assay, and there are several commercial and laboratory-developed assays available. It should be noted that if you do not have a cultured isolate, so if you're using a molecular technique for the identification, Public Health Ontario lab will not be able to perform any antifungal susceptibility testing or further characterization. One challenge with respect to testing for Candida auris is the ability to identify it in the lab. It is prone to misidentification, and not all labs will identify Candida isolates to the species level if they are collected from non-sterile sites. But with this said, most of the labs in Ontario do use automated systems that are capable of correctly identifying Candida auris. If you have additional questions related to the surveillance testing, please contact your local frontline microbiology laboratory. And if you have additional questions about the confirmatory testing or antifungal susceptibility testing, you can contact PHO Labs at the email address provided here, or you can refer to the Public Health Ontario Laboratory Services Mycology webpage. You can also refer your questions to Dr. Juliana Koos, who is with us today, who will be able to answer these questions. So the infection prevention and control measures, as always, require the consistent use of routine practices for all clinical care. The additional key infection prevention and control measures include, of course, the use of additional precautions. So the additional precautions for Candida auris are contact precautions. And so that means we want to have a private or single room with dedicated toileting facilities that are not shared with any other patients or residents. And we want to be able to dedicate supplies and equipment as much as possible to the patient or resident on precautions. In acute care, contact precautions requires gloves and gown on entry to the room for any patient interaction, while in long-term care, contact precautions for AROs require gloves and gown only when you're providing direct care to the resident. And of course, any other PPE as identified by your point of care risk assessment. Additional infection prevention and control strategies that we can use to help control the transmission of C. auris include antimicrobial stewardship, hand hygiene, and effective environmental cleaning and disinfection that we will discuss in a little more detail. So as Pega mentioned previously, transmission of Candida auris occurs primarily through direct contact with contaminated surfaces and the environment, as well as through person-to-person contact. And we have seen persistent environmental contamination despite routine cleaning and disinfection. And contaminated medical equipment and other fomites are thought to play a role in nosocomial Candida auris transmission. So it follows then that rigorous environmental cleaning is absolutely critical to preventing the transmission of Candida auris. Public Health Ontario's environmental cleaning toolkit includes an FAQ for significant organisms related to environmental cleaning that includes all of the specific cleaning recommendations for Candida auris, as well as other organisms of concern. But the specific Candida auris recommendations include using a Health Canada improved hospital or healthcare disinfectant with claims of efficacy against Candida auris, and of course a DIN number. And sodium hypochlorite and improved hydrogen peroxide have been shown to be effective against Candida auris, while quats have not, and so quats should not be used. Rooms and equipment for patients on precautions for C. auris should be cleaned and disinfected at a minimum daily and upon discharge or transfer or discontinuation of precautions. But because Candida auris can persist in the environment for so long, twice daily cleaning can be considered. Hand hygiene and antimicrobial stewardship are also essential in reducing the emergence and transmission of Candida auris. Hand hygiene isn't just about washing your hands more, it's about performing hand hygiene using the correct technique with the correct product at the right time, so following the 4 moments of hand hygiene. And antimicrobial stewardship strategies include limiting the unnecessary initiation of antimicrobials, reducing the use of overly broad spectrum antimicrobials, as well as reducing the courses of therapy. Public Health Ontario has dedicated web pages for both hand hygiene and antimicrobial stewardship that has many helpful resources and tools you can use to implement effective hand hygiene and antimicrobial stewardship programs in your settings. And you can refer to PHO's website to search for the most up-to-date information. So lastly, for me, we will review the DOPHS-related requirements for Candida auris. There are 4 of them, and they relate to reporting, surveillance, lab testing, and case and outbreak management. So the reporting for Candida auris isn't different compared to the other diseases of public health significance, and healthcare settings, physicians, laboratories, and hospital administrators are required to report all cases to their local public health unit, who then report the information to the Ministry of Health using IFIS. The cases that are required to be reported include lab-confirmed infections, and all reported cases, so the lab-confirmed infections, must be investigated to determine the source of acquisition, and the reporting requirements include risk factor assessment. And then finally, outbreak-related data, if and when an outbreak is declared, also must be reported. For lab testing, the first positive isolate from any individual should be sent to Public Health Ontario labs for confirmation. And cases and contacts and outbreaks must be managed in order to reduce or stop the transmission of Candida auris. Earlier in the presentation, Pega had showed you the case management algorithm. This information is also included there. But for C. auris outbreaks in healthcare settings, and this is a little bit different than how we would typically respond to ARO outbreaks, but when a single case of Candida auris is identified in a setting that hasn't seen a case previously, we need to be doing a point prevalence. And when and if an outbreak is declared, the requirement to declare the outbreak over is serial negative point prevalence studies collected at least a week apart times 4. And then additionally, the threshold for suspect and confirmed outbreaks is low. And an outbreak is suspected if a single confirmed case is identified in a facility that has not seen a case previously, or 2 or more confirmed cases are identified within a setting, but even if they present on different units and months apart. And an outbreak is confirmed in a healthcare setting if we have evidence of transmission between patients, if we have an epilink between patients or residents, or if the hospital or long-term care home considers, based on their policies, that transmission has occurred, or finally, if the incidence of Candida auris at the facility is higher than expected, even if no links can be identified between patients and residents. And so with that, I will pass this on to Dr. Lauren Small to share his outbreak experience with Candida auris. Thank you.
Thanks, Catherine. Good afternoon, everybody. It's good to be here. So as Catherine said, I will be talking about a real-world Candida auris experience. This occurred at a large Greater Toronto Area community academic hospital with a diverse catchment area. There are 3 main facility sites related to this institution. The outbreak involved one of the sites, the largest of the sites, which is approximately a 700-bed site. It has 2 medical ICUs. One of the ICUs is an 18-bed and can be expanded to 24 beds unit, which is relatively new, built less than 15 years ago. And it also has a second medical ICU, which is older and goes back to the original building of the hospital. And that's a 15 to 20 bed unit, and that is over 30 years old. The hospital does not at this time have Candida auris surveillance in place, and the organization has never had a Candida auris isolate up until this point. The institution does have a microbiology lab on site. They do mycology. However, the mycology for Candida auris is not validated, and any isolates to be tested for Candida auris must go to a reference lab. So in late 2022, a patient was identified. This was a 63-year-old man who was admitted to the medical ICU about 9 months prior in December 2021. The patient was admitted with fever, jaundice, and pneumonia. They had a past medical history of diabetes mellitus, a laparoscopic cholecystectomy in 2015. The patient originated from the Philippines, coming to Canada in 1989, and had last had travel to Philippines in 2016. Upon admission, after admission on day 2, their condition deteriorated and they had been intubated, and hemodialysis was started soon after admission. So again, this is back in 2021. The patient was eventually diagnosed with granulomatous hepatitis and evidence of disseminated tuberculosis. There was a very complicated course, and the patient remained in the ICU for their entire admission. Throughout that course, the patient had multiple bacteremias and many antimicrobial courses. The most recent was in August of 2022 with a resistant serratia, and the patient had been on meropenem. Of note, the patient also had multiple colonization sites of Candida albicans, and also one active infection with Candida albicans resulting in candidemia, and that was in March of 2022, and that was treated with caspofungin. On August 30th, 2022, so this is approximately now 9 months after their admission, the patient had fever, new fever, with rigors while on meropenem for the previous serratia infection that I had mentioned. September 1st, blood cultures grew Candida, and the preliminary identification of the Candida was Candida auris. A sputum sample later also grew Candida auris. Caspofungin was started. There was some concern about the possibility of caspofungin resistance, and so the patient was changed to liposomal amphotericin. But I believe later on during the treatment, the patient was switched back to caspofungin. It was later found not to be caspofungin resistant, and the patient eventually did recover from this infection. IPAC was notified of this result, and at this point, you'll see there's a footnote, and that has already been referenced. That is to the PIDAC Candida auris document. So from here on in, the institution did follow the PIDAC document for next steps, and I would encourage everybody to look at this reference because it is very helpful, and it was a very informative guide for the management. I'm just going to point out here, just be a little bit helpful as we move forward. This is the layout of the unit. In the non-colored area, so the white area, that is the medical ICU. There is a neurosurgical ICU in red directly adjacent to this unit. It is completely separate. There are doors. However, one does have to pass through the unit, the medical ICU, to get to the neurosurgical ICU. There is usually no shared equipment. There is usually no shared staff, but the path to the neurosurgical ICU is there. You will see the index case labeled in yellow, and it's labeled as case number 1 in room 3118. So it might just be helpful for visualizing. So this initial isolate was sent to Public Health Ontario Laboratory for confirmation. We declared a heightened awareness, which is essentially the same thing as Catherine mentioned. Others term it suspect outbreak. It's generally considered to be the same thing. And we communicated this to our stakeholders and to the hospital at large. The index case was put on contact precautions, full terminal cleaning, including, and if we could just go back, I should just mention this. Although this is the ICU, this is an adjoining room. If you look at 3118 and 3119, they are separate rooms, but they are linked to each other through a shared bathroom. It's the ICU, so bathrooms usually aren't used by patients, but just of note, there is a communication geographically from one room to another through the bathroom. So terminal cleaning, including the shared washroom was done for the index room. Enhanced cleaning of the unit with sodium hypochlorite and increased frequency began. And the contact tracing was initiated for the past 90 days. This included patients that had occupied the adjacent room were considered to be contacts. So then the question became who to screen beyond this in terms of a point prevalence. And as I mentioned, we do have a unit that is connected to another unit, but they are separate units. At this point, the decision was made to consider the medical ICU completely distinct from the neurosurgical ICUs since it was physically separated. The only connection between the two units would be staff walking through or visitors walking through. There was no shared equipment and no shared staff. So only the medical ICU and the contacts were tested in point prevalence. And as per the PIDAC document, again, referencing the PIDAC document, combined groin axilla swabs were done, as well as nares. On September 12th, 2022, swabs from 14 ICU patients and 6 additional patients that had been in the adjacent room and were now in other areas of the hospital were sent to reference lab for testing. They all resulted as no Candida auris isolated, including the index patient. These results were communicated to the organization, and that heightened awareness would not be declared a full outbreak, or the suspect outbreak would not be declared a full outbreak, and monitoring would continue. However, on September 15th, the cultures that were being processed in parallel in the hospital's own microbiology lab had a positive axilla swab on a second patient. So just to recap, the reference lab, that same isolate came up negative, and the parallel processing in the hospital came up positive. Patient number 2 now identified. This patient was admitted in November 2021. So if you recall, we're now in September 2022. The patient had been admitted with anemia and an upper GI bleed with multiple comorbidities. This is a 64-year-old man from Pakistan as well as the UK, came to Canada in 2001, had been in Pakistan since then, and had received medical care in Pakistan. The patient had been transferred to the ICU after a lengthy stay in hospital in June of 2022, and had been in the same room in the ICU throughout the ICU stay. This patient had multiple infections as well as bacteremia and multiple antimicrobial courses. This patient had also been on hemodialysis. The patient never had any Candida auris infections, but eventually did have a catheter tip that grew Candida auris later in the admission. We'll go through this a little bit further and we'll talk about environmental testing, but first, here is just an updated floor plan. You'll see the original index case in yellow, number 1, and the second case that was picked up in red, number 2, so fairly far away, relatively speaking, in the unit. So September 15th, the entire unit is now placed on contact precautions. September 19th, the Candida auris isolate is confirmed and outbreak is officially declared. This is communicated to the entire organization. This is also communicated to ICU patients and their families with information, written information provided to all families. The public health unit is informed. At this time, Candida auris was not yet reportable. we reported it to the public health unit. We engaged Public Health Ontario for further guidance, and the isolates were referred from Public Health Ontario to NML for whole genome sequencing. We engaged in a 90-day contact tracing of patient number 2. No additional patients were identified through that. September 15th and 16th, the second point prevalence was done, and new patients on the unit were also screened, and that resulted in a total of 37 patients being included in the second point prevalence. Now, just getting back to environmental testing, we had to decide if we were going to do environmental testing and how we would do it. We did note that there were 4 hemodialysis units working on this medical ICU, and we did recognize that one of the dialysis units had been used for both of these patients. So based on that, we did decide to do environmental testing of all the hemodialysis machines, and swabs were done of various areas on the machines. And the one shared unit that we identified, we couldn't take them all out of service, but the one shared unit that we did identify between these 2 patients was removed from service. The unit remained open to admissions, and enhanced cleaning was continued. On September 19th, a second point prevalence was done, and the hemodialysis swabs were also resulted, and they were all negative. September 22nd, a third point prevalence was done using the same criteria. This resulted in 30 patients being swabbed, and the third point prevalence came back completely negative on September 29th. On October 3rd, a fourth point prevalence was done with the same criteria. At this point, that would be 27 patients. And on October 7th, the fourth point prevalence came back completely negative, and the outbreak was declared over. Additional monthly point prevalences were done in October, November, and December, and they were all negative. So just a few conclusions and takeaway messages here. This was the first Candida auris outbreak in Ontario. There have been no further cases at this hospital. I have to say that guidance from PIDAC, as I mentioned, as well as other institutions that we reached out to previously had Candida auris isolates, and experience was invaluable. Because it is, at the moment, it is quite rare. So if you do encounter this, I would really encourage everybody to engage people that have had experience. Public Health Ontario consultation provided reassurance because there was so little experience around. And basically, we approached this in parallel and as partners, and it was very helpful. Communication with stakeholders was crucial. We just kept everybody informed because few people are aware of this, except those that may have heard about it in the news recently. But most people aren't very aware of Candida auris. It's not like MRSA or even CPE. Coordination with the microbiology lab and PHO for proper collection and submission was absolutely essential. And I do just want to go back and mention along these notes, I mentioned we did send the isolates to NML for whole genome sequencing, and the isolates did come back closely related. They were 8 SNVs apart, so very closely related. They both had the ERG11 and Y132F mutation for azole resistance. The isolates were also fairly closely related to the outbreak isolate from Western Canada, between 35 to 41 sniffs apart. And the isolates were related to two other Candida auris isolates that had been detected previously in Ontario. So all in all, it was very helpful sending these isolates to NML and getting their input. Experience with other investigations, like CPE investigations, was very helpful in coordinating this to be an efficient process. I think if you don't have experience managing these outbreaks, it does get to be a little bit challenging. So if you are an institution where you've had experience with even MRSA outbreaks, it is a little bit easier because you probably already have protocols in place. I will say that routine Candida auris screening is planned, but has still not been implemented at this institution. The institution is still working on optimizing CPE screening. Once that is done, then Candida auris will be the next step. And then this was brought up earlier in the presentation about the length of colonization and how long to keep patients on precautions and clearance. There really is no standard for this as of yet, and we consider them to be lifelong colonized and would keep them on precautions for life. Like I said, there's no standard for this. So I hope that was helpful. I hope this was really a kind of a real world experience. And I will turn it back over to Pega for the continuation of the presentation. Thank you.
Thank you, Dr. Small. To close out this presentation, I'll review a few key highlights. So Candida auris is an emerging fungal pathogen, especially concerning in healthcare settings due to high resistance to common antifungal treatments. It poses a significant risk for invasive infections and can lead to persistent outbreaks. As of January 1st, 2025, it has become a disease of public health significance in Ontario, requiring enhanced reporting and surveillance. Lab-confirmed cases and outbreak data must now be reported to public health units. Resources to support this process include Ministry of Health's Appendix 1, the IFIS user guide for Candida auris, and the IFIS Ontario investigation tool from Public Health Ontario for case investigation and data collection. Also, I'd like to highlight the resources available on the Public Health Ontario website, which we've discussed throughout the presentation. And of course, as always, remember to clean your hands. These several next pages are resources that you'll find when the presentation will be posted and what we've used as references for the information in this presentation. Please note that the first PHO auris in Ontario surveillance report will be released in the next few weeks, providing a snapshot of Candida auris cases up to the DOPHS designation. Any concerns regarding C. auris, please reach out to your local public health unit. And of course, Public Health Ontario, you can reach us at ipac@oahpp.ca. This concludes our presentation for today. Thank you. I'll now pass it on to Casey.
All right. Thank you, Pega, Catherine, and Dr. Small for kicking off what we hope is an ongoing conversation as we begin to learn more about C. auris. Now a great welcome to Megan Davies, an infection prevention and control specialist at Public Health Ontario, who will moderate the Q&A segment, and Dr. Julianne Koos, an extra panelist who is a clinical microbiologist at Public Health Ontario, where she oversees bacteriology and mycology sections. Dr. Koos has an interest in the use of genomics to aid in describing new pathogens, as well as in understanding pathogen epidemiology, especially in the context of outbreaks. I will now pass things over to Megan to begin the Q&A portion.
Thank you so much, Katie. So just a quick reminder to everyone, if you've not already, please make sure that you enter your questions into the Q&A pod. And being that we're still in the early days, there are still many processes to work out and research that's needed to better understand the organism. However, we will do our very best to answer your questions today. And if we don't get to them or we don't have an answer for you at this time, we will be taking them back with us to guide our next step and our future supports. So without further ado, let's start some questions here. Catherine, I think this one you can take. We have a question. Are all reported cases of C. auris patients in healthcare settings LTC or retirement? Or are we also seeing sporadic confirmed cases and transmission in the community?
Great question. I don't think we have a lot of information on this yet. Making this a DOPHS will certainly help us get a better grasp of what is happening in the province with Candida auris. And as Pega just mentioned, there is going to be a report Public Health Ontario is publishing shortly with information about the cases up until it was made a DOPHS. So hopefully we'll have some information about this shortly. But most of the cases have had travel or hospitalization history outside of Canada.
Thank you, Catherine. That's great. Next question. Julianne, I think this is a great question for you. Is there a risk of greater transmission amongst populations experiencing homelessness?
Also a good question that I think is very similar to the one Catherine just answered. We don't really know. Most of the cases that we're aware of in Ontario have been associated with healthcare, and like Catherine said, with healthcare abroad in many cases. So I agree, making this a reportable disease will help us collect that information, and hopefully as more people are able to get on board with screening and testing, we will have better access to that information. But as far as I know, in other populations, that's not something that is being seen. It's primarily something associated with healthcare institutions at this time.
Thank you so much, Julianne. Dr. Small, this might be a great question for you. Seeing more and more physicians ordering antifungal creams for moisture-associated skin damage or MASD or other rashes, is there any tips and tricks to reduce this? And can the increase of these creams be a concern for increased risk for Candida auris MDRO?
Yeah, I don't know if there's any, thanks for this. I don't know if there's any specific data regarding this. Certainly overuse of any antimicrobials can predispose to colonization, especially with antimicrobial resistant organisms. Since Candida is considered part of the normal flora, if topical creams are used, which are often azole based, there would be some risk of favoring the resistant strains of Candida. And if somebody is already a carrier, or if they are somewhere like in a hospital setting where there might be environmental contamination with Candida, then certainly it could increase the risk of colonization or further colonization with Candida auris, which is resistant generally to azoles.
Thank you so much, Dr. Small. Pega, for you, has UV light been found effective to remove bioburden?
Thanks, Megan. So some evidence suggests that UV light or hydrogen peroxide vapor can reduce levels of environmental contamination with Candida auris. However, it's essential that the room is first cleaned and disinfected using the standard process. So using sodium hypochlorite and improved hydrogen peroxide, and then the UV light could be used as a secondary step to cleaning and disinfection.
That's great. Thank you, Pega, so much. Next to you, Catherine, are there contact management and screening requirements for exposed healthcare workers or exposed household community contacts in non-healthcare settings?
Thanks, Megan. Thanks for the question. There aren't. So Candida auris typically affects immunocompromised folks. If you're hospitalized with invasive devices, those are the people really at risk. And so there's no screening recommendations outside of healthcare settings.
Thanks, Catherine. Julianne, question here for you. What are the characteristics of C. auris that contribute to the antifungal resistance?
The Candida auris has many traits that allow it to be resistant. So one of them is it can grow as a biofilm. So that's either on the person or on inanimate objects. And it also has molecular mutations that allow it to be resistant. Like Dr. Small was mentioning, the isolate that they had the ERG11 mutation, so that results in azole resistance. Efflux pumps allow it to be resistant to amphotericin. And I think it's important to note that even if it's not originally resistant to the echinocandins, treatment with the echinocandins can actually promote the development of resistance over time if the infection's not controlled properly. So there are cases in the States been reported that isolates are pan-resistant to all the antifungals that we have available to us. So many mechanisms of resistance.
Thanks, Julianne. Appreciate it. Pega, so if you could maybe take this question, will there be C. auris on admission screening programs for healthcare facilities like there is for other AROs? Just wondering context in which we at the health units may start receiving positives and when we might anticipate this.
Thanks, Megan. So as I mentioned earlier in the interim PIDAC guidance, the interim guidance for IPAC for Candida auris, all healthcare settings should have policies and procedures for screening, investigation, and care of patients or residents colonized. And so we did recommend using PIDAC's Annex A, as well as the additional precaution and routine practices and additional precautions document to create such screening programs. And of course, we have that screening checklist that we had an image on one of the slides that could also help with protocols and policies developed for screening of patients.
Thanks, Pega. Dr. Small, this might be a good one for you. It kind of relates to the scenario that you had spoke about. If a suspect outbreak is defined as two separate patients, even up on different floors and months apart, who should be included in the point prevalence, contacts only, or all floors each patient had been on?
That's a great question. Given resources, it probably would be challenging to screen everybody. Certainly, our experience was that approaching things stepwise, from the most immediate patients to the most immediate contacts, and then kind of spreading out from there seemed to be the best way and most efficient way to go, because resources for testing were significantly, I wouldn't say limited, but we did have to wait till we had the necessary plates to actually do it, and the number of plates that were available to us were limited. So we did have to really think about how we wanted to approach it.
Thank you so much, Dr. Small. Okay, next question. Catherine, this might be a good one for you. What is the guidance for long-term care homes? Should we be screening all residents on admission for C. auris?
Thanks, Megan. The risk factors for long-term care homes are the same for hospitals for all of the different healthcare settings. And so it isn't universal screening. The risk factors for Candida auris currently are the exposure to a healthcare setting outside of Canada in the last 12 months, transfer from a Canadian facility that has a C. auris outbreak or ongoing transmission, if the resident has a prior history of C. auris, or if they're an exposure. So those are the individuals who should be screened on admission currently.
Great. Thank you, Catherine. Another question here for you, Julianne. Which country is mostly affected with C. auris?
Well, C. auris has been identified almost globally at this point. So the spread happened very rapidly after its initial identification. In terms of where we have seen our isolates or where patients have traveled. You know, the United States, a lot of our patients travel there and seem to have brought it back. But we have had isolates from East Asia, Southeast Asia, South Africa, you name it. So it's all over the place. But the United States, so our closest neighbor where probably we have a lot of travel, has very, very high rates of C. auris. So I would be, you know, wary of patients who had been hospitalized there, you know, probably should be investigated for C. auris colonization if hospitalized in Ontario.
Great. Thank you so much, Julianne. And just looking at the time here, we have a number of other questions which we unfortunately will not be able to get to, but we will collate all of these questions and hopefully be able to put together some responses for a later date. So as we wrap up today's PHO round session, I would really like to thank Pega Ashley, Catherine Kerr, and Dr. Lauren Small for presenting, and our panelists that supported our Q&A portion. I would also like to thank everyone who joined us for today's event. You can expect to receive a brief and anonymous survey for today's session, so please try to complete this to help us improve our program. And with that, we thank you very much for attending today and have a wonderful day.